It's a self-organized panel. We invited them. They talked to each other. They decided on their sequence, talking points, coordination. So truly impressed. So they don't need any moderation. I'll turn it over to them, and they'll each give their remarks, and then we will open it up for Q&A and discussion after this. So join me in welcoming them this afternoon.
Good afternoon, everyone. I don't want to go through the bio too much, but I did think it was interesting to share maybe a little bit about ourselves, because I think we all have unique backgrounds, and I know when I was a student, I always enjoyed hearing about what folks had done as far as their backgrounds. So I actually have my bachelor's and master's in industrial and systems engineering from the University of Florida. And I knew when I was going to do my master's degree, because I had done internships in both manufacturing and health, that I wanted to go into healthcare. So when I was doing my master's degree, I actually took, I specialized in engineering management, so I took MBA classes to do that. But I also used my electives to take some classes in Masters of Health Systems, an MHA, Masters of Healthcare Administration, because I knew I wanted to go into healthcare. And that's proved very beneficial to me, because when I came right out of school, I actually did consulting for a while. And then ever since then, I've been at Northside Hospital, and I've had several different positions there. Right now, I'm the Director of Productivity Management. And so what does that mean? That means that I'm involved and help do all of our staffing for the entire Northside Hospital system. So that's from the point of entry with our physician practices or urgent care centers, all the way through the acute care environment in our inpatient hospital settings, also in all of our outpatient settings. So we have our hands in all of the different staffing, all the different skill levels with that. So I wanted to first of all talk about, I know that we're talking about data. You know, I know as industrial engineers, we love data. You know, and how can we use it? How can we apply it? How can we use it to help make a difference in healthcare? So I'm going to speak a little bit more specifically about the efficiency part, and then some of my colleagues are also going to talk about quality and outcomes, since that's kind of what we're trying to focus the panel on. So why are we, you know, industrial engineers being involved in healthcare and looking at health systems? Well, as we've heard previously a little bit, we have a lot of issues going on right now with our healthcare costs. I think it was referenced earlier, it's about 17.9% of the GDP. And when we look at kind of what's going on in 2019, we've got aging population, we have patients that have multiple chronic conditions. We're having to deal a lot with end-of-life care. We have more and more technology available now than probably at any point in healthcare history. And we have a lot of different drugs and procedures that are also enabling the end-of-life care to be more substantial than it's been in the past. And on the flip side of that, unfortunately, with a lot of things that have been going on probably over the past 5 to 10 years, we're seeing a decrease in our reimbursement. And a lot of that has to do with the Affordable Care Act. We've got bundled payments. We have value-based purchasing, insurance exchanges, the accountable care organizations. If I'm mentioning these words and you're not familiar with them, go Google them. As being in healthcare and doing health systems, you need to know what these are, because they're very crucial to all of the healthcare organizations that we're working with, and also the federal deficit, 2% Medicare reimbursement. If you did not have a burning platform of why you want to be in healthcare and why you want to do healthcare systems, this is a great one. So when we talk about methodologies, I know that these probably look very basic to you, but a lot of times as industrial engineers and systems engineers, when we go into the healthcare organizations, we're working a lot talking about a multidisciplinary team. We're working with clinicians. We're working with physicians. We're working with pharmacists. We're working with nurses. Their area of expertise is not going to be process redesign, Lean Six Sigma, facility layout, optimizing how we set everything up, benchmarking. doing time studies or understanding the data analytics of how their area may work. Their area of expertise is maybe medical. You know, they know how to take care of the patient. We need to help to support them and use our data to do that. So what I wanted to do was talk through a few projects, you know, that I've done over the course of my career, but also help to set the stage for what my fellow colleagues are also going to talk about. So I want to talk about staffing, operations improvement, workflow, capacity analysis, facility design. So healthcare labor management. So this is kind of the bread and butter of industrial engineering or systems engineering in healthcare. I love it. I live it. It's my life every day and has been for the past several years. I get so much joy and pleasure out of being able to help a clinician be able to figure out how many people, what type of people do I need to be able to run my area so that we can provide the best quality care for our patients. If you're a 24/7, 365, we have to figure out how many people we need here to make that happen. You know, how do we do that? How do we make sure that our patients are taken care of? How do we deal with the fact that we don't know the next patient that's going to be coming in through labor and delivery or coming through the ED? So figuring out, you know, having the right people in the right place at the right time, being able to look at what our volumes are, what are our demand patterns, how can we use forecasting, how can we figure all this out? And a lot of that, a lot of that has to do with, you know, productivity management, position management, figuring all of that out. Unfortunately, in 2019, one of the biggest things that we're facing in healthcare is a shortage of healthcare workers. So now we have to start looking at what the skill mix is. Now we have to start figuring out, well, 10 or 15 years ago, we had a plethora of XYZ healthcare worker. RNs were a lot more prevalent than they are now. Even our, you know, lab, our medical technologists that help run our laboratories where we have to do all of the testing, even our pharmacists, looking at respiratory therapists, our rehab folks, physical therapists, occupational therapists, speech pathologists, they are not as readily available as they were. So how can we take care of these patients with a different level of healthcare worker that's out there? Well, those are the types of things that we have to help them figure out. A really, really cool project that I got to work on about 5 years ago, and there's a ton of literature out there now about it, and this actually helped set some precedents that are in place today. So I was able, Northside Hospital Forsyth, which is one of our hospitals up in Cumming, Georgia, started to work on a project in a conglomeration with the IHI, looking at being able to perform same-day total joint replacements. So if we go back, way back in time when these first came about, there was easily, you would have the procedure done, you would be in the hospital for a week, easily. Then as time has gone on and the technology has changed, our surgeons have gotten more and more involved with improving things. We have more and more biomedical engineering pieces about it. There have been strides made in how to be able to do this. You know, this was not even fathomable, you know, 5 or 10 years ago. And so when what I wanted to make the point about with this is we had to use data. We had a multidisciplinary team. We had the orthopedic surgeons, we had the anesthesiologist, we had pharmacists, we had the physical therapists, the nurses, the ones that were in the OR, the ones that were up on the units to help take care of them. And so we wanted to figure out what we needed to do that we could do same-day surgeries. And so we had this whole group work together under the umbrella of the IHI wanting to look at this. And this is just some data to show, like when we started out, you know, pre-pilot, pre-trying to do some Lean Six Sigma changes, we had 15% of the patients were able to be discharged in less than 23 hours. So we did some root cause analysis, we did some Lean Six Sigma, we had all these different clinicians involved. We came up with some very specific things that we wanted to pilot. We did the pilot and it changed from 15% to 42%. That we were able to discharge the patients in 23 hours. And this was back in 2014. So jump forward 5 years, and I think my data is even a little bit lagging because I just had a colleague send me some data this week. We have 92% of our patients are discharged in less than 8 hours that have a total joint replacement. I'm talking about knees and hips. Their average length of stay is about 4 to 6 hours. That's it. There's a lot of pre-work that has to be done. There's a lot of, obviously, post-work that has to be done. But this is amazing, and this is phenomenal. And the fact that as industrial engineers, we get to be a part of a team to help them figure all this out. How do we do the workflow? How do we make this happen is just incredible. And this is just one example. But, I mean, this is life-changing for our patients. The outcomes are incredible for them to be able to do this. Also, emergency department. And I can't mention the emergency department without mentioning the fact of going back to what I was talking about with healthcare costs and reimbursement. We need to have our emergency departments be truly for the acute episodes, and we need to make sure that our patients are going to primary care physicians or urgent care centers for those types of situations that are not, urgent and emergent, because what's happening is then we're impacting the healthcare cost that this country is experiencing. So we did do a project in the emergency department, and again, because of my involvement with staffing, what this kind of stemmed around, we definitely wanted to decrease the wait time for the patients. We definitely wanted to decrease the length of stay for our patients. But what we found is that we actually, one of the things we needed to do was look at how we were staffing our care teams or our pods. I was talking out with a group when we had our break. One of our challenges is that even though we do have our healthcare workers, that more and more of them are novice. More and more of our experienced healthcare workers are of the age where they're retiring or they're choosing to do things differently. So we've had to set up different models. So one of the changes that we made in our care team model was to basically have like a care team lead that would be able to help the nurses and the techs and help facilitate keeping the throughput moving and going so that it wasn't just one nurse or one technologist trying to take care of one patient. They were working as a team. And what we found is that we were able to affect the amount of stay by 20%. We decreased it, and we did discharge to exit because we didn't want the acuity or anything like that to be an impact. We wanted to kind of have more of a pure data point. And by being able to do this and them working together as a team, keeping the flow going, getting the patients where they needed to go and getting them discharged, we had a huge impact. And that's just one example. There's so many examples of different, especially when it comes to our emergency departments and our surgical services area, about improving the workflow and improving the throughput, and that is pure health systems engineering and working in conglomeration with our clinicians. Another thing that we don't really think about, too, that I wanted to point out is access to care. So I know Emory's big with this, Northside is big with this when we talk about cancer. When you are experiencing cancer, the last thing you want to do is have to get in a vehicle and drive 2 or 3 hours to go see your care provider. So I know that Northside has done this. I believe Emory's done this as well. We've created several locations throughout all of Metro Atlanta, even beyond that, like in North Georgia, all of North Georgia, so that if patients do have to get outpatient treatments, that they're only going a few miles down the road from their home. They're not having to travel really far. Obviously, if they have an acute episode, they will, but if they're on a care treatment plan, that they have a very specified regimen of what they're having to do, that they're having to go in 2 or 3 times a week to receive those treatments, how can we help them be as close to where they live as possible. And again, looking at market analysis, looking at forecasting, look at population density to help make these decisions about where we need to have these locations, and then making sure that we have the appropriate staffing and the appropriate equipment to take care of them. My last example that I wanted to go over is also like expansion of facility. So you don't necessarily think about that, but that's a huge impact when we talk about redesigning a facility, or we had the privilege of actually creating a replacement hospital. Our Northside Hospital Cherokee campus relocated about 2.5 years ago. We moved as an 84-bed hospital, and come about a month from now, we will be, I believe, over 250-bed hospital in 2.5 years. And that is by planning, being able to create access to care, being able to have good layouts so that our clinicians have a good workflow and are able to get their job done in a timely fashion. If we know that they need to get to a medication room, the last thing we need to do is have the medication room at the end of a hallway. We need to have that centrally located so everybody can get to it as easily as possible. And that's just one example. I mean, definitely when we're looking at our nursing units, our emergency departments, and outpatient center, no matter what we do, we need to make sure that we're thinking through all the steps that the clinicians will have to take, and how can we make it as efficient as possible from a facility layout standpoint. And so with that, I will turn it over to Victoria.
We'll do Q&A at the end, but while we transition, we could take one question if you have a burning question that you think cannot wait until the very end. Anybody? Okay, all right, Victoria.
Okay. Well, good afternoon, everybody. I realize that I have to start off by apologizing for wearing the other school's colors. I had a whole different outfit picked out this morning, and then it got really, really cold, and this was the warmest thing I could find, so forgive me. Well, my background to get to what I'm doing now, I'm currently the Vice President of Quality for Emory Healthcare for the system. We have 11 hospitals and over 300 clinics. My path to that was not quite as focused as Joyce's. I'm a little older than she is, so I had more time to lose focus. And my undergrad is in statistics. Had no idea what I would do with that, just liked statistics, and was fortunate enough to get involved in quality in the early days of Dr. Deming's reemergence in the U.S. And I worked in industry and manufacturing for many years. Loved it, just fell in love with quality improvement, the whole total quality package from strategic planning to Lean and Six Sigma before it was even called Six Sigma, and just trying to improve processes. And from there, got an MBA at Ohio State when I was working for General Electric up there, and decided to get into consulting. So I traveled 40 weeks a year, out on Sunday night, home on Friday night. Loved it. I was young and single. It was a great thing to do. I highly recommend it before you decide to get married and have kids. Once I did that, I didn't want to do that anymore. Took off about 10 years when I was raising children, and during that time worked on my PhD. Oh, skipped the master's. I got a master's from Auburn in Industrial and Systems Engineering before the MBA. And then went back while I was raising my kids and got a PhD from Auburn University in Industrial and Systems Engineering. And during that time, had I would say a realization that I wanted to do something more meaningful with my skills. Being an industrial engineer, always liking math and science, I always envied teachers and physicians and nurses and people who could help other people, because I thought, you know, that's great, but that's just not me. I'm the math and science kind of person. And so being able to find my way into healthcare was very meaningful for me. My sister passed away during that time from cancer, and I was able to, during her journey, see how far behind frankly, healthcare was for manufacturing, and realized that it would be important to me to try to use my skills in industrial and systems engineering and quality in general to help change that. So worked for Vanderbilt for a short period of time, and then spent 9 years at MD Anderson Cancer Center in Houston before coming to Emory 2 years ago, and just love it. It's very meaningful when you can make a difference, which is not every day, but we'll take what we can get, right? I'll just get into my section, which is sustainability. So once we've made improvements, because everybody up here on the panel, we're all working at applying Lean and Six Sigma and other tools like Joyce was talking about, matching capacity to demand to capacity or vice versa, scheduling, optimization, various things in integrated facility design, lots of opportunities. But what I've found is that most organizations, not just healthcare, have a hard time of sustaining those goals. And one of the problems that I've found with the implementation of Lean in both manufacturing and in healthcare is that typically people think of Lean as just implementing a project. So we bring people in, we train them all to be green belts, black belts, so on, and then we say go out and work on a project. They go out and work on different projects. They may or may not be coordinated, linked to a strategic plan. They may just be what they think is important to work on. And at the end of the day, that process fails. And then the company comes back and says, well, see, I knew that Lean stuff didn't work, right? Well, it doesn't work if all you do are projects. It has to be rolled into a lot more. And so, you know, being able to set up a system to sustain the gains is important. So I want to talk a little bit about how we're doing that at Emory. And so there are two parts to that. One is measuring. Of course, when you do any kind of improvement project, the last step is, you know, if you look at DMAIC, the last step is control, is put in something to sustain those specific goals. And so that's using data, monitor it, right? And then I'm going to talk more about how do we change the whole system to sustain the gains. So as far as data, one of the things that I found in healthcare and quite frankly in industry alike is a lot of people will have scorecards that look something like this. So this is one for patient experience. I don't have the numbers in there, but you'll see the red-green chart, right? You see those tables all the time. And in this case, it's how are we doing relative to our goal, which may or may not compare to national standards, right? National benchmarks. What's wrong with that? Oh, well, actually, you know, some of that is red because we set really high goals. We may be performing better than everybody else, but it's red, so that doesn't really tell us much, does it, if we just look at it and see it's red? What else is wrong with that? Okay, yeah, it's looking at like the last month, which believe me, in healthcare, that's a challenge because like all the CMS measures that you see posted, they're like 2 years behind. So there's like a 3-year average 2 years back. So it's even worse than it looks here. And there's one more problem here. Yes, Connie?
It doesn't really talk about the difference between special cause variation.
Exactly. I have no historical reference. I have no way to know if it's red there because it went up 1 month and was just natural random variation, or we've had a string of them that have gone up or down in this case because we're looking at patient experience. So that's the point. So one of the things that we're doing, and believe it or not, you know, this is relatively new, I would say, in healthcare, is using control charts to understand natural versus common cause versus special cause of variation. So putting all of our data into control chart forms has been a real learning point because people are going, oh, you know, yeah, it went up this month, but it wasn't anything different. It was natural random variation. So one important thing, takeaway, is tracking, sustaining gains by using data to track it is important, but it has to be over time with control limits, with an understanding of what this even means. And so just an important point there. I know probably most of you have had that in school, but There's more. And so the more is, how do we build a culture to sustain continuous improvement? And that's a lot more than just a few metrics, and that's a lot more than a few projects. So in fact, we've started implementing a lean operating system, very similar. You see this if you're familiar with the Toyota production system, this will be familiar to you. But it's much easier said than done, as you can imagine. And so we're right now spending 2 years at least just on this bottom part, which is just getting some of the basic cultural changes in place. How do we have huddles every day, tiered huddles, so that we're escalating problems, the problem escalation. So for example, I'm in quality, so I have a team of infection preventionists who meet, and they'll be talking about, are there particular issues there. They then come up to a larger huddle, which is made up of the whole quality group, and then we go to a system group and to hospital groups. And what you'll start to see is escalation of problems and getting them fixed. And what we've realized from that process is there were a lot of things that we just never, as leaders, never heard about. So our president the other day said, you know, I was really surprised that we had so many materials issues. Well, that's a good thing to know, because now we know what we need to work on in terms of our strategic planning over the next year. So how do we engage leaders, get leaders as coaches, have leaders developing employees in the same mindset, set up visual management boards where we can track all of these things that are important to us and see how we do over time, implementing standard work in both leaders and physicians in every position. And what we've realized is that doing this is really kind of a hard sell, because what do you think's the return on investment from this work? There's not much, right? I mean, this is just foundational first step things that we have to do in order to get to the point where we can start doing more on patient flow and level loading and staffing to demand and so on. So we're investing in trying to get that standard in place for a lean operating system that we can then go into these projects and sustain them. So this is just an example of the tiered huddles, and I'm finding more and more healthcare facilities are doing this these days. If you've worked in manufacturing, you've probably seen this, although some do it better than others. But we start with, for example, a tier 1 huddle would be all the lower levels of, if you look at conglomerating an organization. So I'm talking about maybe a unit, a nursing unit on the floor, having a meeting in the morning, 15 minutes, stand up in front of the board and say, are we ready for today? Have there been any, go through the SMIS, any safety issues, any materials issues, any equipment, and so on. And then we then go to the next level, which would be usually a director level, and say, hey, did anything come from the tier 1 huddle that needs to be escalated? They couldn't address it and we need to address it. Likewise, then rolls up to hospital huddle, and that rolls up to a joint operations huddle, and we actually now even have a system huddle. So we're looking at how do we make sure that we're providing people with the resources they need to do their job well. Dr. Deming used to say, don't provide goals, posters, and slogans without providing a resource to achieve them. And so we're making sure people have what they need to do their jobs. Doesn't do any good to have an improvement project in one area if we then aren't making sure people have what they need to sustain that. But it's more than huddles, and this wheel shows you some of the pieces of the daily management system, which is really leaders' jobs. So as a leader or a manager, this is really your job, how to coach employees, how to make sure they have what they need to do their job, make sure that we have standard work in place, encourage ideas and coordination, communication, and a planned work. So how do we use that to achieve those goals? How am I doing time-wise? Okay. So here's some of the elements. I'll just let you take a look at this, but one of the things we're finding is we have too many meetings. So how do we eliminate meetings? And the concept of huddles goes a long way to that. Many companies that have done that well have found that their number of emails goes down, their number of phone calls goes down, the number of meetings goes down because they're able to work those through right in the moment and relatively quickly. So standard work is a big part of this, and Dr. Esper is going to talk to us about what we're doing for standard work on the clinical side as well as the operational side. Any of you, so he's an exception to this joke I'm about to tell because he's a good team player. He looks for process improvement. We love Dr. Esper, but do any of y'all know the difference between God and a surgeon? Have you heard that joke? No? God knows he's not a surgeon. Takes a minute. Yeah. The point is, not to be disparaging of our physician friends because we love them and they save lives and bring in revenue. It's a very important role. But the traits that make a good surgeon are not typically the traits that make a great team player. Think about it. If you're going to be in the operating room, you're having somebody operate on you, don't you want them to be very confident? And you want them to make decisions quickly and be sure of their decisions and not go, oh, what do you think we should do? And, so the traits that make a good surgeon and in general a good physician are not typically the same traits we see when we have let's get a whole multi-purpose team, multifunctional team together for improvement. So when you start talking about implementing standard work, I work in the quality department. I can come up with my standard work, but if I start asking physicians, they all think that their process is better than anybody else's, right? And so how do you get to the point where they all agree on standard work? That's a real challenge in healthcare. And Dr. Esper and Dr. Bornstein, who I work for, have really done a good job of identifying how a structure that we can put in place to implement standard work across our clinical areas as well as our operational areas. So Dr. Esper.
Hello team, can you hear me? Yeah, I think so. So thank you, Victoria. So I am just so thankful to have been invited to come and talk to you guys today from Professors Kaskinachak and Nazal, who I've worked with in the past. I've actually led a number of industrial engineering senior design teams. I think we won twice or so. We put our names up on the board. We've come in second a couple of times. So it's been a real treasure, really, to work with our team here at Georgia Tech. I think the cross-partnership of Emory University, Emory Healthcare, and Georgia Tech is so powerful for the Atlanta area. So it's great to be here. I'm a neurologist. I see patients for headache, neuropathy, nerve damage, Parkinson's disease, epilepsy, after stroke, and so forth. So that's my clinical role. I'm still a clinician. And my big role at Emory is as the Associate Chief Medical Officer for Emory Healthcare for the system. Our system is now 11 hospitals large. It's over 250 clinics. We have over 22,000 employees. I think we're up to 23,000 employees. And we help take care of people in our local network, which is in the greater Atlanta area, in our regional network, which is the 5-state area, and nationally and internationally for various diseases. So, and in that role as the Associate Chief Medical Officer, I have the privilege of waking up every day thinking about how do we standardize clinical care, and what do I mean by that? So if you or your family member became ill and got pneumonia and your blood pressure, you started feeling bad, and you got to the emergency room and your heart rate was up and your blood pressure was dropping, and an ER doctor said, I think you might have sepsis. what kind of care would you want? Just what kind of care would you want? Would you want evidence-based care, or would you want the care that the emergency medicine physician thought was good at that time that was just kind of haphazard? Evidence-based care. If you were going to have a cardiac catheterization and there were standards in place for making sure that you got hydrated appropriately before your catheterization so that the contrast that the cardiologist used wasn't going to harm your kidney, would you want that standard protocol to be used, or would you want any variation that somebody came up with to be used? If you had cancer and there was a standard protocol to be delivered, would you want the standard protocol to be delivered? And the answers to these questions are kind of obvious. But in medical care, there has been an evolution in medical care of variation. And variation that for many folks feels justified because of their experience or this patient that they took care of 10 years ago or something like that. And so, one of the issues that we have in Emory is that we grew from a 1-hospital system to a 2-hospital system. Emory University Hospital, Emory Crawford Long became Emory Midtown Hospital. We grew from Emory University Hospital and Emory Midtown Hospital, 2 systems, to 4 hospitals. We're adding doctors, we're adding clinics over time. And then most recently, we've added the former DeKalb Hospital system, which is now part of Emory Healthcare. They're a great part of Emory Healthcare. And one of the questions becomes, over all these areas, can we treat sepsis the same way? So that if a patient comes in with sepsis in the emergency department at Emory University Hospital, gets the same care as they would if they came to Emory St. Joseph's Hospital. Does a patient who's getting a cardiac catheterization at Emory Johns Creek Hospital have the same pre-cath hydration pathway as the one patient who's getting their catheterization at Midtown Hospital? And that's what consumes us. How do we function as a system at Emory Healthcare so that any gains that we make in literature, evidence-based medicine, or any of the best practices that we have at one location can be disseminated across the whole system? That's really the question. And that is what basically encouraged us over a period of time from 2016 to 2017 to really start to generate the system governance of clinical standardization at Emory. Well, we formed a clinical practice council. What is a clinical practice council? You can read the definition there, but basically a clinical practice council is a multidisciplinary group. It should be multidisciplinary with nurses, with physicians, with advanced practice providers that come together to look at various standards and make sure that these standards can be deployed across the system to deliver STEEP care. Is anybody familiar with the acronym STEEP, S-T-E-E-E-P? It's from the Institute of Medicine's report in 2001, The Quality Chasm. Safe, timely, effective, efficient, equitable, and patient-centered care. That's the whole goal of the Clinical Practice Council. We desire to make sure that we have standards in place that our physicians, our nurses, our advanced practice providers can deploy every time, every patient, to make sure that they're getting the right care at the right time. The purpose of the Clinical Practice Council is to oversee clinical standardization, but not to make healthcare workers automatons, not to take the thinking out of medicine, but to say, this is the standard. We can make it easy for you to deploy the standard, but we allow appropriate, justifiable variation when it's necessary, because not all patients are the same. And we have to make sure that we give the clinicians who can think the ability to actually say, you know what, I actually need to alter the pathway slightly in this situation to make sure they're getting the exact right care. It's to make sure that we had a place to offer input on important funding decisions. So for instance, let's say we're in the middle of a budget year, and it turns out that we actually have to implement a change in the way we test for something like Clostridium difficile, which is a bad infection that can happen in the gut. And that change requires a $200,000 investment. And that's we haven't planned for it in the budget, and it's something that we think is important to the healthcare system and to the care of the patient. How do we actually make a decision as a health system to actually spend that $200,000 on that as opposed to something else? That's where the Clinical Practice Council can give clinical input to our system operations team to make sure that they can help make that decision. To address the prioritization of the implementation of competing clinical initiatives. So who's familiar with information technology? Thank you. Half of the room, and we're at Georgia Tech. That's great. I'm just kidding. Information technology is very difficult in a health system because we have a bunch of folks submitting a tremendous number of information technology improvements all at the same time. What do you do first? Do I make sure that the standard pathway for status epilepticus, somebody who's continuously having seizures, gets done first? Or do I make sure that the upgrade to the oncology power plan for breast cancer gets done first? Which one do I do? How do I do it? That's where the Clinical Practice Council can be part of the solution. We can look to see how wide the standardization is and how we can implement it. To facilitate system-wide resolution to gaps in care through enhancing coordination between interdisciplinary providers. Example. So let's go back to our patient in the emergency room. The blood pressure's dropping. The pulse is going up. They have a high white blood count. It looks like they're septic. An alert fires on the electronic medical record. Positive sepsis or sepsis trigger initiated. Nurse, please screen patient to see if they are septic. The nurse screens the patient and says, you know what, the blood pressure is going down, the heart rate's going up, they have a fever and their white count's elevated. I think they're septic. I'm going to screen them positive for sepsis. That would trigger the physician to come and say, hey, is the patient septic or not, to confirm that we're going to go along the sepsis pathway and give them the full evidence-based pathway for sepsis. Well, at certain times, there was disagreement between the physician and the nurse as to whether the patient was septic. Did we screen them positively appropriately? Did we not screen them positively appropriately? And it's especially difficult in certain scenarios like oncology, where the patient may not be able to have a high white blood count, but they look like they're septic. And so there's this interdisciplinary nurse-physician disconnect as to whether the patient should go on the sepsis pathway. Well, one of the things that we did in the Clinical Practice Council is to actually bring that together and say, we think that this is probably evidence-based medicine. You should err on the side of actually doing this. And that way we can actually try to deliver the right care and look back and actually err on the side of delivering the evidence-based medicine and then look back and see, are we delivering it appropriately? So that's an example of that. Provide a system-wide forum for quality and safety data review. This actually is developing as we move forward. We're actually reviewing quality and safety data in different areas. The Clinical Practice Council will be one of them. And right now it's very disease-focused, but we're going to be moving it forward into more of a system focus in the Clinical Practice Council. And that bottom point is so critical. Anybody in here want to be a physician? Anybody in here want to be a nurse? Anybody in here want to be an advanced practice provider? Anybody want to work in healthcare? Hopefully a couple of you. We want to make sure that if you want to work in healthcare, that you have joy of practice, that we're not doing it in a way that is burdening you to deliver the care that you need to deliver, but that we're actually making sure that we're streamlining things so that you can actually have joy in your work, that you're not getting killed all the time, and that you can actually see the forest for the trees and make sure that your existence in the healthcare world is actually a positive experience for you, which will decrease burnout and will make you last longer in the healthcare space. And that's a major principle for why we've developed the Clinical Practice Council. What does the Clinical Practice Council look like? Well, so there are a lot of voting members. I think we're up to 39 voting members. What's the best number of voting members generally on a council that the literature says? 7. We have 39. It's great. So we wanted to err on the side of making sure that we had representation from our Emory University Hospital, where we have our chief medical officer, our chief quality officer, our chief nurse officer, and our chief of staff, going all the way across from Emory University Hospital, Midtown Hospital, St. Joseph's Hospital, Johns Creek, our outpatient clinical practice. Make sure we have Winship Cancer Institute involved because they're so massive. Our Emory Healthcare Network, chief medical officer, chief quality officer is there. Our newly added former DeKalb medical system is also added to the Clinical Practice Council, and we also have our Kaiser Permanente team who are now sending their patients to Emory St. Joseph's and Emory Johns Creek. So we needed to have robust representation of nursing and of physicians, and as well as to make sure that it was broadly distributed. You'll also see that we have voting faculty who are chairs. We have a couple of spots to fill out. A couple of our private practice people are now off the council, and we have yet to replete them. We have the president of the Advanced Practice Provider Council and our director of APPs, Bonnie Prue, is there. We have a clinical nurse council representative. We have 2 of them. Cindy Oster is our patient safety scientist in nursing. And of course, we have our GME represented by our Dean of Graduate Medical Education. And we also have one of our residents who is representing the resident body on the Clinical Practice Council as well. So we try to have a robust representation of people that can say, hey, wait a second, you forgot about the residents. When you're implementing the sepsis power plan, you didn't think about what the residents are doing, or you don't think about how the nurse is being affected by the sepsis power plan. And then we have a bunch of non-voting people here who are supposed to support it. And we also have our CFOs and our chief operating officers who are ad hoc. When they need to be in the room, we can invite them. Now, you can't come to Georgia Tech without a colorful slide that has swim lanes. So we put a little swim lane slide in place to make sure that everybody can see the process. So what does the process of standardizing clinical care look like? So let's say Joe Schmo wants to come and says, you know what, I think we need to standardize this. So the first thing we do is we do a lot of pre-work. We say, okay, how do you want to standardize it? What do you want to standardize? And is it going to be a system standardization, or is it going to be a lower level standardization at a hospital? So for instance, in oncology, most of our oncology work is primarily most of our inpatient oncology work is at Emory University Hospital. It wouldn't necessarily make sense to standardize across all the hospitals. But if we wanted to standardize something across all the hospitals, do you have all the right buy-in? And that's this first swim lane here. So the clinical topic gets chosen in any number of these ways. A bunch of clinicians want to do it. Management identifies an opportunity. A team is chartered through a value acceleration process. The Office of Quality says, hey, we need something worked on here, such as the new VTE, venous thromboembolism prophylaxis. And we need it worked on, and we need it systematized and standardized. So a clinical topic gets chosen. A subject matter expert group is chosen. And then they go through this where they look at the topic scope, they get data around it, and they say, okay, how do we want to standardize it? They inform the leadership early on that this is being worked on, because you have to inform leadership that something's being worked on, because you don't want to surprise them on the back end and say, hey, this is what we've done. So then that goes into the next part of the swim lane, which is actual presentation at the CPC, at the Clinical Practice Council. They get 15 minutes, typically, to present, and they get 15 minutes of questions. There's a standard slide deck. They get 2 slides for background. Some people come in with 8 slides of background. I chop it down to 2, because we don't want everybody talking about the background. We want people talking about what is the solution being presented, how is it going to affect clinical care, and does it need to get moved forward or not? Does it need to go back for further input? Things happen at the CPC, like really broad discussions. So for instance, when our diabetes group brought the inpatient standard insulin power plans for standard basal dosing of insulin and correctional table-based dosing of insulin, it all looked good. And what happened was, at the end, somebody said, oh, hey, what are we going to do on discharge for the patient? how is their outpatient doctor going to know how we've adjusted their insulin on the inpatient side? And the team, who had done outstanding work, said, we don't have that. And the Clinical Practice Council said, well, before we can ratify it, you got to go back, develop it, and then bring it back. That's the reason for a Clinical Practice Council, to make sure that we try to think of everything that's patient-based. Are we delivering patient-based care that is not going to disenfranchise the patient and the family? Once the CPC approves a clinical standardization, then we submit it to the board patient quality committee. Why the board? Because the board is what ultimately governs the medical practice at Emory Healthcare. And so we submit it to the board and say, do you agree with our standardization? And typically the board agrees, because a few real estate folks really don't want to say, you know, we don't agree with the doctors or the nurses or what have you. But they typically agree, but it's a very important step. It's an important step because it says the board agrees that this is the standard of care at Emory Healthcare. That's a clear signal that allows us then to make sure that that standard can happen in an appropriate fashion. The board reviews the recommendation. If they agree, they send a letter to the medical executive councils and say, guys, this is the new standard. Gals, this is a new standard. Do you agree with it? It gives local autonomy to the medical executive council to say, no, we don't agree with it. And here's why. Example, when we standardized who could determine if a patient was brain dead, okay? Because there are very specific standards to determine who can be brain dead and who is not. For instance, you can't determine brain death if they're on opiates. You can't determine brain death if their temperature is 35.9 degrees Celsius. They have to be 36 degrees Celsius. There are a lot of other standards by which you could determine brain death. Well, we have a whole protocol for that. We need to make sure that people are trained to do that. One of the aspects that got held up in the medical executive council at Midtown was that the obstetrician had to be when a woman who was pregnant, if God forbid if she was brain dead, what they were requiring was that a maternal fetal medicine specialist would need to confirm viability of the fetus or not versus just an obstetrician who doesn't have specific training in maternal fetal medicine. And that was something that Midtown, for instance, wanted adjusted. They said, you know what, we think that an obstetrician can do that without having need of a maternal fetal medicine specialist who may not be on call or who may not be available. So that was an adjustment that the MEC made based on their local methodology and how they do things. So generally, and if the MEC doesn't agree, they typically will have to either talk about it, or if they really don't agree and they don't want to implement the standard, they actually have to submit a letter back to the board, and they have to appear before the board and say, why don't we want to accept the standard? And we've been doing this for almost 3 years now, and that has not happened. And again, most of these are well vetted by the time it gets to the board patient quality committee. So I can show you data on how our performance has improved on sepsis care, on pre-cath hydration, on cost and quality. I can show you a number of different slides on, yes, ma'am.
I have a question.
Yes.
Sorry.
Sure.
The things you described here, which are really amazing and terrific, do you apply them as well as the primary care setting, or are they specific to your acute care setting?
So it's a great question. So the physician group practice, we have a number of councils. For instance, the Diabetes Council and the Opiate Stewardship Council, and a number of councils that do a lot of work on the outpatient side. What we don't do is require standards to come through that are kind of no-brainer standards. In other words, so for instance, how many narcotic pills are allowed to be distributed post-surgery on the outpatient side in a discharging prescription? We wouldn't want that to necessarily come to the Clinical Practice Council, because that's something that that can be standardized without too much, so to say, argument or discussion. It can be done. The physician group practice has a lot of their own governance system that they haven't, that they are able to submit standardizations through without bringing them to the Clinical Practice Council. And so for the most part, the clinical standardizations that have happened have mainly been acute care based. ICU, acute care, and so forth. It is a good point that says, what should we be bringing to the Clinical Practice Council on the physician group practice? For instance, what are the access criteria? So if, when you have, certain specialties like neurology that don't have a lot of access, and how do we actually take care of those access problems? What are the goals? Are we going to actually change the way we have access? Are we going to do e-consults? Are we not going to do e-consults? Those types of things. That may wind up coming to the Clinical Practice Council. It has not as of today. But it's a great question. Other questions? Oh, other questions later. So, very good. I hope I didn't go over my time.
It's always hard to follow God, right? Can you ever follow God? I'm just kidding. So, it's amazing. I think the presentations were really impressive. As far as the focus of my presentation, I'm going to focus more on, there's a lot of things happening globally, nationally, that are influencing change in healthcare. So I'm going to take a step back. The continuous improvement work and all of that is necessary. But as we are in this transitional phase to get into a new phase of healthcare where changes are necessary, the environment demands that from us. What do we hope that journey to look like? And then what we as industrial engineers can really contribute towards that. So, and it fits really well with the focus of our session here today of the next generation. What is the next generation of health systems going to look like? So, like I said, we are essentially transitioning from an old world to a new world in healthcare. So what I mean by that is, as you talk about moving away from volume to value, it's all about not seeing more and more patients in the acute care setting or the outpatient clinics. It's about how we can provide the preventive care and how we can keep these patients out of coming to the hospital. Now, that's a big driver, and that's where healthcare really needs to go, and we saw some of the presentations in that regard this morning. And like I talked, which is really forcing a lot of hospitals that really operated in an acute care setting environment about patients showing up at the ED and then how they're getting admitted to the inpatient beds, right? One of the metric that hospitals still continue to track is admits through the ED. You really want that number to go down, not go up in the new environment. So what that's forcing health systems to do is not just think about their hospitals, but talk about how can we have urgent care centers instead of patients' conditions deteriorating. Can that be tackled in the urgent care center? How can we have more preventive visits with the primary care providers so the patients are having their vitals regularly checked and not reaching to a situation where they really need to be operated on? Dr. Esper talked a little about burnout and bringing joy back to the providers. We also know because of so much fluctuation happening in the market, we are really understaffed. There is a huge acute shortage of providers, specialists, nurses. You talk about it, and there is a huge shortage to that. So it's important for us to make sure that healthcare, especially clinicians being in that profession, is not considered to be a dissatisfactory job, because we want more providers to be coming out of the clinics. And then provider-centric to patient condition-centric. So again, this kind of gets down to, there's a lot of patient consumerism happening, where I, as a patient, really want to go to the best and the greatest provider that has amazing outcomes, that has great quality to offer. So patients are becoming more educated and have a lot more awareness, and that's another big factor that's influencing our health systems that's going to drive that standardization. And then the last one, You've all heard about digital. Look at how the market has disrupted in so many industries because of all the data that's available and all the information technology research that's happening. Now, that is also happening in healthcare, and that's really transitioning. Up until now, we often talked about has a hospital implemented an EMR, or whether it's standardized or not standardized. But now we are talking about 90% of the acute care hospitals have already implemented EMR. What are we going to do with the zillions of data that's going to come out of it, and what are we going to do about it? And we really need to push that towards the digital technology. So that was at a global level. Now, what is that forcing the provider organizations to do? When I say provider organizations, it's where that care delivery is happening. It could happen at an outpatient clinic, or it could happen at a hospital, right? It's really forcing systems to merge or come together, like Dr. Esper talked about, right? 11 hospitals. They started with 2 hospitals. Now it's a system of about 11 hospitals that have come together to be able to realize economies of scale. Going back to the value and volume construct that I gave you, you want to have, instead of having 10 cardiologists that are doing everything within the umbrella of cardiology, you want providers to really be specialized. And we can only do that when they're able to really come together and realize those economies of scale, as an example. Provide differentiated services, right? Again, Joyce talked a little more about how you want to open up those access points, and you can really be able to afford all that when a lot of systems come together. And then the last one there also talks about experiment new business models, and I'll get to that in a little bit here. So really, again, talking about the construct of how it's disrupting the healthcare market, you know, a lot of business professionals really study this concept as the S-curve. What that is when the business is really starting to get influenced by so many environmental factors, you need to disrupt how care is being delivered. And that's what the lower end of the curve there is saying, the different strategies health systems are adopting. Now, the reason I included this slide is this is also forcing health systems to start thinking about how can we transition from continuous process improvement to really be able to capitalize on the data that's available and also apply those advanced analytics principles to be able to move to those solutions that are going to be more proactive in nature. And then the next few slides, I'll walk you through some simple examples that we have done within our system today. So one of them is related to population health management, right? We heard a beautiful presentation from Nisha this morning around how we really need to be able to improve the health of our communities so they are able to really identify what are some of those problems or some of those clinical conditions that can be prevented so you don't have patients really showing up to the emergency department, going back to the example I gave you. So, you know, again, applying analytic principles here, we have been doing some geospatial analysis to understand, are there certain pockets of the community that are bringing a lot of, that are having a lot more readmissions after they are treated within the hospital, and then what is that distribution of chronic illness across the community so we are able to provide the preventive care necessary. Joyce talked a lot about productivity and labor management, and I talked to you about how there's a shortage of labor. And as the slide states, there's a huge vacancy rate. Nurses are critical. We are trying to push a lot of care to the nurses because they are a lower level licensure. But hospitals and health systems are really competing in this environment and struggling, which is requiring us to really be proactive. Instead of waiting for that attrition to happen, you're requiring to really predict what that attrition rate looks like and almost, in a sense, overhire so you are prepared to really face those situations when you're not going to have enough nurses and you can bring down that vacancy rate. Then patient satisfaction, you know, it's amazing. Talk about the Amazon experience you have today, right? You go to the hospitals, the nurses and caregivers are so caught up in trying to juggle through the EMR and really sort through providing clinical care, we are forgetting the fact that the patient sitting in front of you has certain needs, and it's very important for us to address those. We have all the patient satisfaction surveys that Victoria walked through, but keep in mind, patient satisfaction surveys too are so focused around the HCAP survey, it's so focused around the basic needs, right? Is your facility clean? Of course it needs to be clean. Are you getting the attention from the caregiver, or is the caregiver responsive to you? But in that, just looking through those metrics, although again, I would emphasize that's the starting point, we need to get to a point where we are able to really also start to understand and analyze the comments that are really provided by those patients, because those are personalized to the patient condition. A really complex patient might have completely different needs compared to a patient that's getting a knee or hip surgery and can start walking the next day. How do we start to analyze that through the comments they're providing? And that's where a lot of text mining and a lot of analysis around that space is happening to be able to drive that. Then last but not the least, and in my mind personally, that's where healthcare is going. It's the P4 medicine, which is personalized, predictive, preventive, and participatory. A great example of that is, how many of you have Apple Watch? Do you have the health app that really gives you your ECG? Right? So talk about artificial intelligence algorithms that are analyzing a lot of data, the signal data that you get from your heart rhythms, and are able to proactively give you diagnosis of certain conditions that the signal is providing. Before I moved to the health system in Macon, I was at the Mayo Clinic, and I was very closely working on this project. Believe it or not, as some of those algorithms were getting validated, the ECG algorithms that are really providing you a proactive analysis around atrial fibrillation, as we were doing some of that validation, the ECG algorithm was also giving you the ability, or was very accurately predicting the age and the sex of the individual. So talk about power of data and what it can do for healthcare. Talk about the standardization that it can bring, working closely with the clinicians, and what decision support it can provide to our clinicians. So with that, I'll leave you on the note that as industrial engineers, whether it's analytics, whether it's continuous improvement, whether it's standardization, there is a lot we can bring to this industry, and I want you to reflect on what you can do for this industry.
Much to all our panelists, fantastic comments and lots of food for thought. So we are going to opening up for questions. I'm happy to pass the microphone to those of you who may want to ask questions or provide comments, share thoughts.
I'm curious, what challenges have you or your organizations faced in regards to new regulations on electronic health records implementation or integration? My bad.
Well,
Where to start?
Yeah.
just throw a softball, why don't you?
Yeah.
That's a great question. I will actually talk about a regulation that is about to happen. And it's called appropriate use criteria for imaging. So CMS actually in 2015, as part of the Medicare Access and CHIP, the MACRA Act of 2015, the part of that act was that that in order to make sure that we're getting imaging on appropriate people, there have to be appropriate use criteria for the imaging. That was actually supposed to be implemented in 2018. And what that means is that there's a significant amount of effort that is required on the front end to be able to have a scan approved for payment on the back end. So as a neurologist, appropriate use of an MRI would have to be done for things that are not primary headaches. And so a primary headache is something like migraine, or a primary headache is something like tension headache. And so one of the issues would be, well, what's the appropriate use criteria for getting an MRI for someone with a headache? And how does that get justified on the front end compared to the back end? And there are a lot of actually decision support systems that actually need to be implemented to be able to do that. They were so intensive that Medicare backed off that requirement for 2018, but it's going to come into place, I think, in 2020 or 2021, I'm not sure. So we are scrambling to try and figure out how to do appropriate use criteria implementation in the electronic medical record, to be compliant by the time that it is actually required by Medicare to make sure that the imaging gets paid for. So that's just one example of difficulty.
I'll just give you a bigger picture view of it. There are two main vendors for EMRs, Cerner and Epic, and that's it. And those were primarily designed for billing. And yet, it's evolved over time into much more. So all of the publicly reported data that you see on CMS websites and so on is really coming from that coded data. It's not necessarily clinical data, which is why there are other organizations like NSQIP, the National Surgery Quality Improvement Program, and Vizient, used to be UHC, other organizations that look at more clinical data. But all of that is primarily this administrative coded data. In order to get the right reimbursement, you saw Joyce's chart about how our reimbursements have gone down. In order to get the right reimbursement, or the most you can appropriately get, you have to be coding correctly. And that has put a lot of burden on the physicians to make sure they're getting the right information captured at the time they're seeing the patient. So many of you, I'm sure, have been to see your doctor where the doctor's sitting in front of the computer and looking at the computer more than they look at you. And I think that's one of the biggest problems that it's caused us is that it takes time away from the physician with the patient, and it also has a serious impact on the joy in work that Dr. Esper talked about earlier, because physicians didn't go into medicine to enter data into a computer. They went in to see patients and to heal, and so they see it as a real conflict. So I think there are a lot of bigger picture problems with the medical record that we don't have easy answers for. We don't, some people will do scribes. We were talking about that earlier. That's an added cost that we don't have the money to pay. So how do you, it's a real catch-22. It's a very difficult problem for us, but it causes a lot of trouble, I would say.
I will say that Mark Bronstein here at Georgia Tech is a real champion of FHIR, Fast Healthcare Interoperability Resources. And we are looking to FHIR, and we've actually implemented a FHIR governance committee at Emory to see how FHIR can be implemented overlaid atop the electronic medical record to help us with some of these problems. So that's an example where the industrial engineering and computer science from Georgia Tech can actually help healthcare systems like Northside and Emory deliver better care to the patients.
Sorry, I promise we can get off the EHR topic after my question if you guys want. I'm Francis. I work at Piedmont Healthcare. So I think it was touched on a second ago in an earlier question. We've been trying to basically take all of the inpatient standardization success that we've had and translate it into the ambulatory space. And for all the reasons that have been talked about, including the fact that, it's not just 2 EMRs for us. It might be, somewhere between 20 or 30 across our entire clinic network. I guess outside of EMR standardization, is anybody up there incenting physician behavior with any value-based arrangements or anything you've seen to sort of help push physicians who are not on the same system to try to drive to the same standard of care?
I have an answer. I have an answer for that, but I'll defer because I've been talking a lot. So, the Emory. I'll give you an example from the Emory Healthcare Network. So you're exactly right. when the Emory Healthcare Network started in 2011, a lot of our external physicians who joined the network as private practice individuals and private practices had eClinical Works, they had Athena Health, they had a bunch of different electronic medical records. And we had to make a decision, how do we actually not disincentivize those physicians from joining the Emory Healthcare Network, but at the same time take 42 different electronic health records and integrate them together? Well, we had to make a decision, right? So we said, well, we're not going to take 42, but we are going to take 10. And they were going to be like the 10 top ones. And we developed an interface called the HIE, the Healthcare Information Exchange, which, again, many groups have. And the HIE is a central repository for data from these electronic medical records. And now we're actually one of the only clinically integrated networks in Georgia that actually has 100% of its external groups, not with Emory, not our faculty practice and not our Emory Specialty Associates employed physicians, to have 100% integration, the private practice docs, 100% integration in the health information exchange. And we can see that information in our master Cerner Millennium data set. So you have to make decisions, you have to stick to your governance on that decision, but then you have to make it easy for them to actually implement. And so it's a great question. Now, I don't know if I answered it completely, but yeah.
I think that the value thing too is how we, short of having that warehouse that brings all the charts together, we're trying to say, hey, if you do these things, we can reward you for performing that statement of care, even if we're
Yeah.
able to monitor internally or lagging, but still somewhat accuracy.
Yeah, and you're talking about performance on value-based contracts.
Share some of that.
And so so it's actually interesting because this year the Emory Healthcare Network said the primary care physicians are really, we want to incentivize the primary care doctors to deliver the care coordination, et cetera, to keep the patients out of the higher acuity levels of care. And so it was agreed upon by the Emory Healthcare Network board that the primary care physicians would share in the savings once it gets, there's a division of savings, but that the specialists actually would benefit that from the referrals of those patients for the higher levels of care. So again, decision-making, board, everyone kind of come together for that type of decision-making.
All right, so first off, I wanted to say each of the presentations was really insightful, really empowering, and I have a lot of questions that I could ask, and there's a lot of thoughts that are going through my mind right now, but something that Joyce was talking about earlier about ED workflow and reducing it by 20% and discharge to exit time. So something that I've thought about was, first off, what were you said you decreased it by 20%. What kind of things did you do to decrease it? What was implemented to actually decrease the time? And second, you talked about rebuilding your Cherokee Northside location. And so something that I've also thought about is, have you ever considered building a kind of like an emergency department or emergency room location with a urgent care clinic attached to it, so that you can divide, you can assess patients on their acuity and send those patients to the urgent care while you're, treating treating your emergent patients. So you can say, you might say, oh, we've increased our access by building this new primary care clinic, but in the meantime, all those patients are always going to be coming to the emergency department. So why, have you thought of building an urgent care connected to an emergency department? So they come to the emergency department, they get assessed, and then all they have to do is take maybe a bus ride or a simple just connection to an urgent care. and then they could be, so that it reduces the emergency department overflow.
Well, I'll answer your latter question first. So there's so many different ED models out there right now. There's even like a virtual ED, like that the patient never even gets to a bed. So, there's so many different, ways out there right now. But as far as like about, assessing the acuity of the patients, a lot of EDs have gone to models where they are doing the triage, and then they do have where they partition off the patients, whether if they're a lower acuity, that it might be that they need to get stitches or they, sprain their ankle, those types of things. They have an area that they can put them in and do more of a virtual ED because there's not as much of that critical care that needs to be provided. However, obviously, if you have something a lot more traumatic, that you have a trauma area that those, physicians and nurses can be doing those types of things. So I would think a lot of EDs are doing that. I can't say that every one of them is, but I think to take a step back from there, we really have to work with educating our patients on the fact that if they do have a sprained ankle or if they do have a headache or nausea or whatever, that probably the first thing they don't need to do is walk into the ED. And so that gets into, yeah, right. That gets into, having that education, having them have either a primary care physician or having some way that they can get that treatment without having to set foot in an ED, which is our most expensive care that we have.
Before you go to the other question, let me just add, it's actually against the law for us to not treat a patient that walks in the ED. So we can't just say, oh, you don't really need this, you can go to urgent care. But the triage serves that purpose. Basically, we have an urgent care built into the ED, if you will, to do that. But the other point I think is really good, and that is that's why you see a lot more hospitals partnering with urgent care centers and trying to get that word out there that, if you're part of the Emory network, then these are the urgent care centers that you are also covered by. So it's like you say, it's education, but I just wanted to make the point that unfortunately, we can't just say you don't need to be in the emergency room. You can go take a bus to the urgent care. But we basically accomplished that same goal.
So you can look up EMTALA if you don't know that, and then familiarize myself with that, because yes, that is a regulation. But then as far as like, there's so many different pieces. This particular project was looking at the fact that if we have a care team, so we've kind of potted out, the care rooms, because if we're like a 40, 50, 60 bed ED, we're basically having care teams taking care of a certain number of patients or patient rooms, if you will. And so what we found was that if the nurse or the tech was functioning in a more siloed format, like that was their patient and they were doing that care, that then there wasn't somebody else to kind of help pick up the pieces behind them. So what we found, without really adding anything to the staffing, but reallocating how the staff was utilized, that by having a care team lead, that they were able to facilitate getting the patient from the waiting room and putting them into the empty room when the nurse that may be their nurse was finishing up with the other patient, or maybe they were trying to get the x-ray done or get the x-ray order in so that that patient could go get that taken care of, and the other person was filtering in the next patient that they could help do. So we found that it was more creating kind of that coordination of care versus continuing to function like in a siloed way of care. And that really did improve us being able to discharge them more quickly by 20%. The ED is a great place for that. I'll also say labor and delivery is a great place for that, to really have a care team model of working collaboratively and not siloed, which so many people are used to. I do my work, I'm getting it done, and not collaborating with everybody to get everything turned over much more quickly.
And one of the reasons that you hear about lean so much in healthcare is that we have so much waste. It's just a tremendous amount of waste. And so anything that we're doing to reduce waste is going to increase throughput and reduce wait times. The best example in terms of the most profitable one I've been involved in was with an infusion center at MD Anderson, where we were able to reduce waste in the process and then also stagger the staffing to match demand and stagger the patient demand to the point where we were able to increase our utilization so much that it resulted in $20 million a year in increased revenue. So there's tremendous opportunity in healthcare.
I want to make one point quickly on ED improvement. It's important, especially when we talk about lean principles, that lean is a customer-focused system. So we always have to be thinking about the impact of waste from the customer's perspective.
Yep.
So you can do a lot of great work in reducing the ED length of stay, which is what we should do. But actually, we had an interesting problem that happened at Emory in that we actually had patients being discharged with labs still pending on their discharge. And so one of the perspectives of the patient is, well, what did my labs show? Because they may have gotten their lab results in the old system with the longer length of stay in the ED. But when you have labs still pending, how do you actually get those results back to the patient from a customer-focused perspective? So you actually have to think of the entire value stream from the patient's perspective. And so we had to implement an entire process to make sure we got labs back on the back end to the patients after they were discharged. So just the concepts of lean, how they impact the value stream, and how improvements in one area of bottleneck can actually produce constraints on the other end, theory of constraints, et cetera. So, yeah.
Oh, hi, my name is Linda, and I'm a second-year master's student in public policy here at Tech. So earlier you talked about how physicians really hate spending more time with their computer instead of looking at their patients. But at the same time, all the information that they're inputting into their EMRs and EHRs are so valuable for making decisions in evidence-based healthcare. So how do we get around this? How are we able to free up physicians to spend more quality face time with their patients while still getting the same amount of data?
That could be the subject of your dissertation. Be great. You can come help us with it.
Well, I think that there are a number of things that are happening currently. One is, there are human solutions that Victoria alluded to earlier, which are scribes. We are actually implementing a new care model in our primary care clinics where one physician will be partnered with 2 medical assistants. And those 2 medical assistants will actually be not only doing the documentation, which is essential to the electronic medical record, and inputting orders and so forth with the physician's oversight, but also to make sure that the physician actually has the appropriate interaction with the patient. So that's a model that actually Christine Sinski from the American Medical Association has championed, and we're actually trying to implement it here. UPMC actually is developing a virtual model of scribing, a virtual scribe model, where they're actually listening to the visit and actually developing a note without the physician having to do anything. That's in generation right now. That's not, we'd love for Georgia Tech to come to Emory and beat UPMC. So, so those are, for instance, 2 examples, one human-based and one automation-based, that are trying to keep the same amount of information going into the electronic medical record for decision-making purposes, while yet preserving the physician-patient relationship.
Okay, so I really would like to take more questions, but we are kind of at the end of our time. So I suggest we wrap up, and then we still have our posters and some more food outside, and continue the discussion. So please join me in thanking our panelists and all of the other speakers. Thank you. I would like to give a couple of closing remarks, just reflecting on all the great things that we heard today from our rapid-fire presenters, panelists, and also some of our poster presenters outside. Thank you so much for your participation. So we heard that the U.S. healthcare spending has been increasing as a percentage of our GDP, but we do not see a corresponding improvement in our health outcomes or efficiency or effectiveness so far. So that's a big issue for all of us in terms of utilization of our resources. There's a lot of waste in clinics, in hospitals, bigger picture healthcare system, Part of it might be due to how we run our healthcare operations, but also how medicine is practiced. We heard about over-testing, over-medication, or gaps in continuity of care. All of these contribute to some of this waste. And exacerbating these problems is that our demographics are changing. Aging population is growing. We have a lot of people with multiple chronic conditions that's been growing. So all of these end-of-life care, how much time, money, and effort is spent on all of that is contributing. So during our rapid-fire discussion, Dr. Nisha Bachway emphasized the importance of social conditions and how they impact our health outcomes, more so than, say, our genetics or healthcare services. And especially when it comes to chronic conditions, we need to think about our infrastructure, big picture, whether it's physical infrastructure, health infrastructure, and how changes we can make in our environment can actually encourage healthy choices, including education and engagement starting at an early age. All of these could make a huge difference in what we see in later time. Leanne West from GTRI talked a little bit about the kind of technology that's developed here at Georgia Tech, from drug development and devices to analytics, to help us better understand health outcomes and also disparities, and to better allocate our limited precious resources in this space. So I want to emphasize again Georgia Tech's collaboration with fantastic partners. Some of them are represented here today, and Leanne mentioned Emory University Children's Healthcare, Marcos Autism Center, AFLAC centers, and so on. So we really appreciate these collaborations, bringing different perspectives together. And one of the reasons of this forum is to hopefully add to these collaborations or expand on what we are doing. So several education programs at Georgia Tech, also both at the undergraduate and graduate levels, to engage them in research through these collaborations. Dr. Yajun May and Dr. Yao Shi talked about statistics, machine learning, big data, and how we can use some of these tools, again, in collaboration with partners, to answer some of the pressing questions in medicine or healthcare. So very interesting panel discussion. Thanks again. I want to share just a couple of highlights that stood out for me. Joyce mentioned emergency departments for emergency patients only, and the importance of improving workflow and throughput to better use our resources and to achieve better outcomes. I think we've heard this theme a lot in our discussions today. Limited resources. What's the best way to utilize these resources so that they actually help us achieve what we are hoping to achieve in terms of patient outcomes, as well as provider satisfaction and patient satisfaction. Victoria pointed out that sometimes we make improvements. We are very happy and proud about them, but how do you sustain them in the long run so that they don't become one of projects, we clap ourselves or pat ourselves in the back, but how do we make it sustainable over longer term? She emphasized the importance of having some context when we talk about metrics, data, monitoring our performance, that don't think about in isolation, but really have a big picture context, and to promote a culture to ensure continuous improvement, because things change. So what we have done today might work great, but a couple of months or years later, we might need to reevaluate what we are doing. So having this focus on continuous improvement. Greg talked about how we can establish evidence-based standards for clinical care, so everybody doesn't do what they feel like the best thing to do at that point in time, to ensure efficient, effective, equitable, patient-centered care, again, leading to better outcomes. And especially if you think about healthcare being provided by different people in different locations sometimes, and how do we coordinate and make sure that we have care continuity. Tarun talked about the changes that are either necessary, we have to do it, or we want to do it because it's desired, focusing not just on acute care, but to expand our services and focus to end-to-end care, including preventive services, and in some cases possibly reorganizing the way we operate to achieve some scale and better coordination across these different components in the system. He shared an excellent example of combining emergency room readmissions to population health so that we can actually identify at-risk patients and take proactive action to make sure that they receive the kind of care they need and don't end up back in the ED again sometime soon. And in some cases, we can do our best, but prevention may still not be enough, which means we still need to have good methods to identify disease at early stages and offer proactive, personalized care to ensure good outcomes. So the big question that we try to address today, and we'll probably continue addressing for a while to come, is how do we move from sick care to health care? Right? So we call health care, but the way we practice and experience it is for the most part, it's sick care, not necessarily health care. So we want to provide the right care at the right place at the right time, care defined broadly, again, not just treatment after someone gets sick, but proactively to promote health and well-being, again, paying attention to access as well. So I'm a systems engineer, so I'm going to promote, we need to take a systems approach, collaboration between engineers, medical and public health professionals, city planners, economists, many people, right? So because these are very complex problems, and such collaborations offer a lot of potential for addressing some of these complex issues at the root, and not with a kind of Band-Aid approach. So going back to Dima's comment earlier, we are professors, we love to give homework. So your homework after today is to think about what you learned, reflect on some of the things, takeaways from today. Think about what you can take away and share with your colleagues, classmates, others at your organization, or the constituents that you serve, what action you can take, what action you want your organization, your group to take, and how can we also motivate others to take a positive action in this space. So I'm going to leave you with all of that. Thank you again, all of you, for participating today, and I again invite you to continue the discussion outside. Thank you.